Nancy, thank you very much. For those of you who are new to us and have not been to one of the Plato events in the past, welcome. I'm glad you're here. I know you're going to enjoy this. And as Nancy mentioned, the last colloquium of the year is going to be on May 17th, so please mark your calendars. I invite all of you to join us then. Our speaker is going to be Lynn Bavrick, who is a professor of political science at UCLA, and her topic will be Identity Crisis, the 2016 presidential election, and the battle for the meaning of America. So I think we're going to be in for a wonderful session, and I hope you could all join us. At the conclusion of Tom Priselac's remarks, we will be having a question and answer session. We do have two of our wonderful volunteers, Fred McLean and Paul Saylor, who will be walking around with the microphones. If you have a question, please raise your hand. Please wait for them to come to you with the microphone, and please stand up so that the speaker can see you. Our speaker today is Tom Priselac. Mr. Priselac joined Cedar Sinai Medical Center in 1979 and has been president and CEO since 1994. He currently holds the Warsaw Law Chair in Healthcare Leadership at Cedar Sinai. An authority on healthcare delivery and policy, Tom Priselac is a past chair of the American Hospital Association Board of Trustees and a past chair of the Association of American Medical Colleges. When he was chair of the American Hospital Association in 2009, he had an instrumental role in the development of the Affordable Care Act. He formerly also chaired the California Hospital Association and the Hospital Association of Southern California. Right now, he is a member of the Board of Counselors of the Charles Drew University School of Medicine and Science, a member of the Civic Alliance, the Los Angeles Coalition for the Economy and Jobs, Los Angeles County Economic Development Corporation, and Los Angeles Area Chamber of Commerce, and in his spare time he also runs a hospital. Mr. Priselac earned a bachelor's degree in biology from Washington and Jefferson College in Pennsylvania, and a master's degree in public health and in health service administration and planning from the University of Pittsburgh. Please join me in welcoming Tom Priselac.
Thank you very much, Hank. Thanks for the kind introduction and the invitation today. It's a pleasure to be with you all this afternoon. It's nice to see individuals in the room that I know from other aspects of my life, including some golf friends from time to time, but perhaps most importantly, many physicians in the room, or several physicians in the room that I've had the pleasure and privilege of working with over the years. So let me just say in advance, whatever I tell you, they're going to keep me honest. So this should, hopefully this will go well. It really is a pleasure to be with you today and to talk about this issue. It's obviously something that affects us all in pretty profound ways. And so during the course of my talk briefly today, I'll just like to touch on two things. One is kind of the changing healthcare system in terms of financing and things of that nature, but also to spend a little time talking about where science and research is in medicine today and the things that are emerging kind of right before our eyes. I will say in advance, I'm not a physician, I'm not a scientist, so when we get to that segment of it and questions, I won't be able to go too deep, just a forewarning. What I'd like to do on the first half is just chat a little bit about how we got here. And I think that's vitally important because it informs very much where we are and has implications as well, and is part of the challenge, frankly, that the country's facing as far as where we go from here. Talk about what it means to try to reform the healthcare system and what the challenges of that are, and then talk a little bit about the future as I see it, which I can tell you my crystal ball is not clear at all. I'll give you my best sense of, I think, some alternative directions that things may take. So briefly about Cedar Sinai, I know many in the room know it well, or at least to one degree or another, but I just want to set the stage because oftentimes, as the saying goes, where one stands depends on where you sit. And so my perspective has been largely influenced by the many years I've served at Cedars-Sinai, but also in my involvement with the organizations that Hank made. So Cedars-Sinai is the largest private hospital in California and the largest private hospital actually in the western United States. We are the largest provider of Medicare services in the state of California by almost a factor of 2. The next closest hospital has about half the volume of Medicare patients, and a third of them are what are referred to as dual eligibles. So these are elderly individuals who are also poor, and they're covered by both the Medicare and Medi-Cal programs. Separately, we're also a major provider of Medi-Cal services in the state. About 15% of our activity is paid for by patients covered under the Medi-Cal program. As I mentioned earlier, we're the largest, but that's not really why we exist and what we're setting out to do. We always set out to be the best, and fortunately for 20 years now, in public surveys on this question, we're fortunate that people identify Cedars-Sinai, more people identify Cedars-Sinai as their preferred hospital than anyone else. I believe that comes from a sense of humility, frankly, that we can always do better. It's a unique combination of both a community hospital, perhaps like St. John's that some of you are familiar with, or Good Samaritan, or other like institutions, where we provide basic hospital services, obstetrics, routine surgical procedures, treatment of pneumonia, things of that nature, to some 3 million people who live within our service area. But we're also the largest provider of the most acute, tertiary, and quaternary, is the word in the business, services to people requiring everything from organ transplantation, cancer treatments of one type or another, heart treatments of all type, neurosciences, things of that nature. And so we are a unique mix of those two elements of the healthcare delivery system. We also have a mission of education and research. In the time today, I won't go into that, but we are one of the nation's leading education centers for physicians and nurses and others, as well as our research activity, which I will touch on briefly. So let's take a look at where we've been. And as I look around the room, many of us in this room came into this world before things like Medicare and Medicaid even existed. In my own case, I know my grandparents, when I grew up in Pittsburgh, both of my grandparents died, I believe, younger than they would have had they been born 30 years later. Because in those days, what health care you got was largely a function of what you could afford to pay. And it's been 60 years now, but I think sometimes that memory, the memory of those days and what that means disappears, I think, unfortunately, for some people's consciousness. That expansion, I think we can't underestimate federal policy decisions when it comes to health care. They drive a significant amount of what happens in the field. Now today, about 17% of the entire American economy goes to healthcare services of one type or another, which presents certain challenges, and I'll chat about that. But again, going back to the beginning of both the Medicare and the Medicaid programs, as well as, frankly, the expansion of commercial insurance by employers, really had in mind certain specific policy goals. One of them was to enhance access, to give people access to physician and hospital services that they otherwise wouldn't be able to afford to do. The other was to tap into the ingenuity of American healthcare and American science. And the world since 1965, there's no question that America has led the development of research, medical research for the world. And that too, I think we shouldn't underestimate. The mechanisms, as I said, have been both employer-sponsored insurance as well as government finance programs like Medicare and Medicaid. Medicare and Medicaid today account for some 60% of all of the spending in the country. And the projections are, just because of the aging of the population, where there's some 10,000 people now as the baby boom generation moves into its senior years, some 10,000 people are turning 65 every day in the country. if you run those numbers out by about 2025, 70% or slightly more, depending on the economy and depending on how many people are covered by things like Medicaid, will be paid for by government sources of one sort or another. And there are challenges associated with that I'll speak to in a minute as it relates to commercial insurance. And those two things, as I said, really have been an engine of growth for healthcare spending that's occurred since then. So in terms of the implications, I think that there are several that I've just touched on. One is in the area of medical research. And my characterization is that there's good news and bad news. The good news and the best news is that the discoveries that have occurred fueled by the American research and development community, whether it's in pharmaceuticals or devices or other aspects of medicine, has allowed the things like life expectancy and other measures to increase dramatically. When I started in the field, in many hospitals in America, if you came in with a heart attack, there wasn't much more a physician could do for you than put you in the bed, give you some nitroglycerin, give you some aspirin, and hope for the best. Today, one of the things that CedarsSinai has been involved in is the application of regenerative medicine, where we did the first adult heart stem cell transplant in the world several years ago. So we've moved during that time, and in those intervening years, by the way, the ability to both prevent heart attacks and treat heart attacks more effectively, and I'm only using that as an example, has on the one hand, in the good news, bad news story, the good news is people are living much longer, and the incidence of those diseases and the mortality from those diseases is dropping. At the same time, as people live longer, they then experience the other diseases of aging, which adds to the total spending question. So that's when I say good news, bad news. I want to be clear. There's nothing better than all of us living as long as we can. But from a financial standpoint and some of the challenges facing the country, that's some of the background. With regard to health care access, since the Medicare and Medicaid program were established, until the Affordable Care Act, essentially there's a certain segment of the population that were insured. But at the time the Affordable Care Act was passed, some 40 million people in America did not have health insurance. And so with the passage of the Affordable Care Act, at least at the time, the process was put in place to see that number shrink, driven by the belief by some individuals, but not all, and that's part of the challenge we face as a country, is the dueling opinions about this question, that the richest country in the world should be able to figure out a way to get people, everyone in the country, at least certainly all citizens in the country, covered by insurance in some way. But that's as we've seen since the passage of the Affordable Care Act, there was a debatable point at the time the Affordable Care Act was passed, and it remains a highly debated point in the country today. From the quality standpoint, there's no question that when the American healthcare system works at its best, it is the best in the world. There's a reason why people come from all around the world to places like CedarsSinai and other organizations in America, because they know they are going to have access to the best available medical care that they can get. But at the same time, the healthcare system in general, on the quality and safety side, is also uneven. And there are physicians in the room who I think would acknowledge that there are some of their colleagues that they may not refer a friend or family member to, and there are some hospitals that they may not want to see one of their patients admitted at. That's the challenge at a larger macro level in the American system. And then there's the issue of cost. As I said, the American healthcare cost is 17% of the GDP. And the struggle that is going on is both at the federal level and for employers and for individuals. How can it be made more affordable? And there are multiple challenges to that. And I think it is the fundamental domestic policy question the country faces right now, is how to make sure that the promises that have been made to individuals will be fulfilled in the future, and we will continue to have a healthy healthcare delivery system itself. To illustrate the financial issue and the financial challenges, what this shows is the increase in, this is now commercial insurance, shift from government funded to commercial insurance. Average annual premiums in the United States for an individual is in the red bar. The average for family coverage, family of 4, is in the blue bar. And you can see that since basically going back to 2001, the costs of each of those have gone from $2,600 a year to $7,000 a year on the family side, $2,600 now up to $6,700, and for a family from $7,000 to $16,000. The Cliff Notes version of what is contributing to that, 2 things. One, advances in healthcare that are allowing us to do things we couldn't do before. But the single biggest driver has been the growing gap between what it costs to care for Medicare and Medicaid patients versus what the government pays for. And every hospital in America looks to try to balance their financial books and continue their role in their commercial prices. And the gap between what the government paid in 2001 is much smaller than what it is now. And that ends up getting translated into commercial insurance prices. To illustrate the challenge from a society standpoint, this is data regarding the real household income at various percentiles. And as you can see here, the median household income, so half the country is above this and half the country is below this. But the median household income in the United States is some $59,000 a year. So going back to this slide, if you're making $59,000 a year, and it involves as much as $16,000 a year in insurance for health insurance, one can understand why individuals are challenged to be able to get this kind of insurance. So where are we today? We're really in an era of unprecedented change in the American healthcare system, both in terms of the number of changes that are going on as well as the magnitude of the changes. There are significant efforts by both the federal government as well as commercial insurers to stem the growth in healthcare spending. And that's played out in a variety of ways. Maybe if you're interested, we can go into more detail in the Q&A section. Because again, I started by saying that back in 1965 and until about 10 or 15 years ago, the fundamental policy position in the country was to fuel growth of the healthcare sector. Now, as the federal government tries to balance all of the other demands on the federal budget with what is available and possible politically, tax-wise, there's a significant effort to not only, at a minimum, slow the rate of growth, flatten it out, and in many people's minds, reduce that in absolute dollars in order to make room for everything from infrastructure development to tax reductions to defense spending. It's just a lot of, we all know there's a lot of competition for dollars. The methods that that transformation is taking place has largely been through market forces. Essentially, supply and demand and fundamental business economics playing out in the negotiations between, in the case of the government, remember in the case of Medicare and Medicaid, there's no negotiation. The government sets the price, and what they are willing to pay is what anyone who is willing to provide that service to those patients receives, and they essentially agree to accept it. On the commercial side, a whole series of and enormous dynamics between commercial insurance companies, physicians, and hospitals with regard to payment of services for them. In different states, commercial health insurance is largely regulated by the states, not by the federal government. And so what you see around the country is a patchwork quilt of different degrees of public oversight, regulatory oversight of premiums and things of that nature. In terms of the future, trying to touch on both the government side as well as commercial insurance, a couple of thoughts. Part of the debate in Washington is what to do with Medicare going forward. And in its simplest form, the question is whether Medicare should continue to remain what's called a defined benefit program. So all of you who are on the Medicare program, you've contributed to that over the years. And for that, today, you have access to physicians and hospitals and those services that are covered. Another view of the world suggests that in order to solve the cost problem, that Medicare funding should be moved to what's called defined contribution. A fixed amount of money will be paid by the government to individuals who are on Medicare, and it will be up to them to purchase insurance in the marketplace themselves. Again, the idea of trying to use market forces to influence healthcare. I think that's met with a great deal of resistance, not the least of which is, I think, the concern many people understandably have, I believe personally, that the market for healthcare is not the same as the market for other things that we all buy in our day-to-day life. On the commercial insurance side and in your working lives, you probably, being in California, which has led the way, by the way, in many of these changes on the commercial insurance side, in your working lives, you may have experienced as well, different changes in the employer's plan about how much you pay out of pocket. And the amount that individuals now pay out of pocket for their commercial insurance has risen dramatically over the years. And then finally, we're seeing here in California an effort, there have been efforts that have been explored in other states to look at what's generally referred to as a single-payer alternative, which is better thought of as largely a tax finance system. Because even in countries that may use something like that, it's really a tax finance system. It may have one or more payers, but where the money comes from is typically through the tax system. And there's active interest in that in California. Vermont tried to do it, failed. Colorado tried to do it, failed. And that's largely because both the political and the financial realities of a single payer system, despite what one might believe, what anyone's philosophical beliefs might be about how things should be done, there's a substantial financial cost to adopting a single payer system beyond what's being spent today, at least in the short run. With regard to access and medical research, I think the jury's out with regard to whether more people will actually secure coverage. The insurance market is getting more and more challenging for people to be able to afford to buy commercial insurance, and the whole debate and fight that took place over the last 12 months in Washington has been about the question of Medicaid and the degree to which Medicaid should or should not be expanded. And so one of the things that makes the country great is the various opinions that exist. Those differences around health care are what we see playing out in all of our day-to-day lives. On the research side, and I'll finish my presentation with some comments about this more, but the good news is it's, again, that good news, bad news story. The good news is there will continue to be some rather remarkable advances made in medicine in the future. But they will come with the challenges of affordability. And so, again, many of you read in the lay press yourself the challenges with regard to some remarkable breakthrough drugs that have the ability, in some cases, a drug called Sovaldi, which literally solves hepatitis, cures hepatitis. It costs anywhere from $60,000 to $100,000. And so, how does one balance that question? So very fundamental ethical questions, I think, will continue to challenge the country in the future. What you'll see in general is a significant move to personalize what's generally referred to as personalized medicine. Let me come back to that in a moment. And on the healthcare delivery side, the technology around information technology only in the last 5 to 10 years has finally caught up with what's required in order to apply information technology in a healthcare setting. For years, there was criticism of the American healthcare system for not adopting the use of computers and things of that nature. And I'm sure the physicians in the room will be the first to tell you it's not so great even now. But until then, the underlying technology to deal with the complexity of what it takes to computerize healthcare as compared to banking. And I don't mean to offend anyone who is in the banking industry, but it's a lot easier to develop the software for the banking industry than it is for healthcare. But that technology barrier has been crossed, and now there are a variety of different applications that are being done, building on the electronic medical record to really do two things. Number one, hopefully support physicians and nurses and others as they care for the patient through things like clinical decision support to help people sort through the myriad of alternatives that are available in treating patients, but also at a larger level, at a population level, to be able to understand some of the dynamics going on in a given region or a given geography that might help inform public health interventions and things of that nature. And lastly, what we are seeing, there's no doubt, is the development of more organized systems of care. So people in the room are likely generally aware of, and several very well may be members of Kaiser. Kaiser, in that case, is a very advanced form in the sense that in one organization, they have an insurance company, they have a physician group, and they have a set of hospitals. In the rest of the commercial insurance world, physicians and hospitals are integrating and coming together in order to hopefully provide both higher quality and more cost-effective care going forward. Let me switch, and then after this we can move into to Q&A, which my experience is always the best of these things. One is just a little bit about Cedars-Sinai's history with regard to medical research. We've had a significantly active research agenda at Cedars-Sinai since the early 70s. It began with the development of a device called the Swan-Ganz catheter, which the physicians in the room are familiar with, but to give you the Cliff's Notes version, it literally revolutionized the way that patients suffering from heart disease are treated. And that was a technology that spread around the world and continues in use today. Many of you are familiar with minimally invasive surgery. Once upon a time, if you had to have your gallbladder out, you came and you spent a week to 10 days in the hospital. Today, you can get your gallbladder out in the morning and be home with your family at night. That's all, that and orthopedics and other kind of things have all benefited from advances in minimally invasive techniques. Cedars-Sinai was part of the national group that developed that technology. We've also developed products that have basically been put into the Red Cross and Green Cross internationally to make the blood supply safer around the world. We've developed a variety of software programs of one type or another that are in use in many of the diagnostic devices that are in use today. And in the interest of time, I won't go through these others. They're fairly self-explanatory. One last example I made in the area of kidney transplants. In organ transplantation, one of the issues is organ rejection. And our scientists developed the identification of the mechanism and how to basically prevent rejection that might otherwise occur in patients requiring kidney transplantation. So in terms of, again, and this, my comments will be at a 30,000-foot level. The way I would suggest is we've moved in the last several decades through several eras. In the 50s through the 80s, a lot of medical discovery and research was oriented around chemistry. Things like cortisone, things like various chemotherapeutic agents that were the stalwart and really the only available option for the treatment of many cancers once upon a time. Things like ACE inhibitors to control problems in the heart and other things of that nature. And that largely, most of the discoveries were in that category. In the 30 years between 1980 and 2010, it was maybe an era of biomechanics. The development and sophistication of pacemakers, as an example, the development of artificial joints that today are being put in, again, on an ambulatory basis, stents for treatment of heart disease and other kind of things. All of these really occurred in this biomechanical era between 1980 and 2010. Today, and for the foreseeable future, we really are in an era of genotechnology. So the mapping of the human genome, the ability to understand the genome of individuals, the ability to connect that to their diagnosis and treatment is, as we speak, especially in diseases like cancer, It's starting to fundamentally change the paradigm for both diagnosis and treatment. Nanotechnology, the things that, if we remember, I'm going to blank on the name of the movie, Fantastic Voyage. If you remember Fantastic Voyage, there's not a human inside of it, but there are devices that are basically being used to do things like break through barriers that exist in the human body. So in terms of brain cancer, for example, there is what's called the blood-brain barrier. While medicines can get delivered to other organs of the body, getting medicines to the brain is very limited. And so there's work being done today using nanotechnology to break through that barrier because it's small enough and deliver those treatments to the patient who requires it. All of this is leading to, the word of art is personalized medicine, where rather than the relative trial and error approach for medications and things of that nature that has characterized medical treatment to date, where a physician uses their best judgment based on your disease to decide what medicine to give you, by being able to better understand your genome, save the time, get you more effective treatment more quickly, and also avoid the cost of giving you a medicine that fundamentally doesn't work because of your particular genetics, and get you quickly to the one that's most effective for you. Again, in the interest of time, I won't go into it, but there are similar discoveries going on with regard to health services delivery. The whole area of imaging, which has been around, imaging in its basic form of x-rays has been around for years, but there are new advances being made in things like PET scanning and MRIs and other kind of things that are, again, facilitating this personalized health. And so, using cancer as an example, and these are examples, there are things that we're doing at CedarsSinai along these lines, but they're also being done at other major research and clinical centers around the country. Coming out of this discovery, things like, as I said, DNA sequencing, being able to sequence quickly at a relatively low cost. It used to cost $100,000 at one time to sequence an individual's genome. I think the cost now is approaching something like $1,500. I may be off, but not by a lot. And so the lower cost that is, the more this will be able to be useful in diagnosing. In the area of cancer drugs, again, with the ability using computer modeling, being able to identify what drugs may be most effective, and immunotherapy in cancer, using the human body's own built-in innate immune system and strengthening that or triggering it to work again as part of the mechanism. I already mentioned nanotechnology. Stem cells, I mentioned in a minute, is a whole area of work that is being developed as well. I mentioned imaging. Again, changes in the imaging that are mostly allowing incredibly fine resolution images that allow physicians to see things that one couldn't see before because of literally the limitations of the imaging technology itself. There are robots, not unmanned robots, but robotic instrumentation that is able to enhance the quality of the surgical procedure, largely through the ability to avoid implications for surrounding healthy tissue. And then, as I said earlier, both on an individual basis and on a population basis, tapping into information technology to be able to improve diagnosis and treatment. These are some of the things that we're working on just by way of example. So analyzing the human genome to identify drug resistance in aggressive bladder cancer. We have a team working on understanding why are people, what is it about their genes that is causing them to reject it? When one needs a biopsy, oftentimes that's a surgical intervention of one type or another. Technology we're working on to be able to do that with a blood sample by picking up the tumor cells as part of the diagnostic process. I've mentioned already immunotherapy and the idea of developing vaccines, and as well as the use of nanotechnology to penetrate tumors that may not be otherwise accessible. And then we're doing important work in terms of the understanding the genetic mutations associated with precursors to things like acute myeloid leukemia. So before one develops that, there are other stages and other clinical signs of something heading in that direction, and this will allow us to be able to do that. On the regenerative medicine side, we have one of the leading regenerative medicine centers in the country. And as I think I mentioned earlier, we actually did the world's first adult heart stem cell transplant a few years ago, where we took the patient's own stem cells. The scientists did their magic in the laboratory, re-injected them into the patient, and so formerly damaged heart muscle tissue is regrown and allowing the patient to avoid heart failure and organ transplantation eventually. We're also doing the first in human trials for regenerative medicine in ALS, Lou Gehrig's disease. Both of these, again, I want to make sure I'm clear, both of these technologies are still relatively early on in their development, but there's no doubt about their efficacy. Their potential efficacy has been proven. The question is, can you get it to the level of effectiveness that warrants bringing it into the clinic? And the last I'll mention is we've developed with some scientists from MIT and Harvard something that's referred to as an organ on a chip. I failed to bring it along with me, but essentially imagine a lucite chip that's about this big, about 2 inches by 3 inches by 2 inches in diameter. Through one channel flows blood, through the other channel flows pick your medicine that you're trying to identify whether it's going to be effective for that person. So rather than, again, going through trial and error, be able to do that with essentially by use of the technology. So I hope I've given you some sense of some of the changes going on both in the financing and delivery of healthcare, but also the science and the research front. I'd be happy to take questions.
Here's how the question and answer will work for those who are not familiar with the procedure. Fred and I have a microphone. We will hand it on this side and on that side to people who have their hands up. If you get the microphone, when you need to speak, you'll push the button up and a green light will light. Yes, green light will light. And then wait till the person on the other side has finished before you do your side, and we'll alternate. So if someone there has just finished, then it's this side's turn. And if someone here has finished, it's the other side's turn. So we can start on this side with this gentleman here.
Thank you very much for coming today.
Mm-hmm. You may have to talk into the very top. Yeah.
Today. Can you hear me?
Yeah.
One fast question.
Sure.
Are you prepared to accommodate more patients in your emergency rooms as more and more doctors refuse to accept Medicare?
The question, well, everyone heard the question since we have the microphone system. So a couple things about the emergency department. So as Hank said, I've been at Cedars-Sinai for 40 years. During that time, we've remodeled our emergency department 4 times. Every time when we finished building it, we were 25% oversubscribed in terms of demand by the time we finished it. The short answer is yes, both because that's who we are in terms of accepting everyone who walks in through the emergency department. It's part of the ethos of the institution. It's also part of our legal obligation. I want to be clear about that. But in terms of the values of the organization, with regard to physicians and besides that, but to complement that, let me say the following. I would encourage you to not use the emergency department unless you need the sophistication of what is there. Toward that end, what we are doing is we've built a series of what are referred to as urgent care centers that are available anywhere from 12 to 15 hours a day with the ability to take the kind of things that are more routine. That, and then with the ability, if the patient really requires emergency or hospital treatment to arrange for the transfer of that. We're also, within our physician organization, part of the organization, working on expanded access of a variety of things with same-day appointments and things of that nature to be able to accommodate some of the demand. But in the end, the emergency department is there and will be the place, it is the place where people continue to go. And we're working quite hard, actually, on, and the physicians in the room know the challenges of moving patients through the emergency department for those who need to be admitted upstairs. So both operationally and physically, we're committed to doing what's necessary to make sure people have access to service as much as possible.
If I could.
Mm-hmm.
It's green. I put you on the spot. Can you give us a relatively short answer as to why it is that we are spending twice as much money per patient in this country than other countries in the advanced economic group are covering their entire population for half as much?
Right. Yeah, thanks. That's a topic that's hit some of the, I think the New York Times picked up a professional article on that question just the other day. And I applaud them for pointing the way to the answer to your question. First, with regard to spending in the United States, is what I was alluding to. There's a significant difference in terms of how much government pays for health care compared to commercially insured people. Not to minimize what people who are covered by either Medicare or Medicaid pay. I don't mean to minimize that all, but it's dramatically smaller than what happens in commercial insurance. The reason that commercial insurance costs as much as it does, and the reason why all of American healthcare costs as much as it does, the primary reason has to do with the cost. American healthcare is more expensive first and foremost because everyone who works in American healthcare, whether they're doctors, nurses, pharmacists, people like me, people who work in housekeeping in hospitals, people who work in food service in hospitals. Everyone in the American healthcare system makes 2 to 3 times what their counterparts in other developed European countries do. That's been, and now, again, that's what I tried to say earlier, it's good news, bad news. In terms of that reflects what has been a policy position in the country, conscious or otherwise, that wanted to see the healthcare sector expand. And today, some of the best middle class incomes in the United States are in American healthcare. And since 2000, employment, and everyone's worried about the unemployment rate. Employment healthcare is where people are getting jobs compared to other places. So that's part of the challenge, is because if you're going to change that, then you have to ask yourself, what are the implications of that, both for the individuals who are working in the system and from a macro standpoint, where's the economy, you know, what's going to take that place to fuel the economy? It's a very complex question, but the main reason is how much people make in the field. And by the way, in all of the related parts of the ecosystem, pharmaceuticals, the computer people who sell into healthcare, everything, it's one of the best paying places in the country. Nurses now in California earn approaching $100,000 a year. They deserve every penny they get. They work very hard. It requires very intelligent people. And the same is true for pharmacists and others. So that's part of the challenge. The other driver is we use healthcare more. A friend of mine has a way of describing, he says people he's Scottish by birth and lived in Canada and then came to California. He said people in Scotland think death is inevitable. Death is imminent. Canadians think it's inevitable, and Americans think it's optional. And I've had the opportunity to spend time in Germany and Austria and Switzerland and England and places like that. And I can tell you the demand for a titanium hip replacement so you can still have your Saturday morning game doesn't exist to the same degree. It's cultural. It's Americans want options, and Americans want the best. And that's fueled a higher demand, which is the other major driver. And the use of technology, the third driver. Americans love technology. And we make more use, we do more MRIs, we do more CT scans than is used in those other countries. Some of that, I would just observe, some of that's the consequence of financing systems in those countries that have limited, as you limit the rate of money available, you, by definition, you limit the rate of growth. And I'm not saying it's good or bad. It's not a criticism, it's just an observation. That's how it plays out. So that's what I would offer. Yes, sir.
That's great. Okay. You had indicated before that about 70% of your patients are covered by Medicare or Medicaid at this point.
Right.
What would happen to your hospital if it was a single-payer system? Have you thought through that?
Yeah. So I'll answer it in part at a macro level, not just for Cedars-Sinai. If there is the difference statewide in California, the difference between what it costs to care for Medicare and Medicaid patients in hospitals in California versus what the government pays is $8 billion. Commercial, if that $8 billion of underpayment for treating Medicare and Medicaid patients didn't exist, commercial insurance prices in California could be reduced by 30%. In terms of your question, if basically things went to a Medicare and Medicaid level, we would. The short answer is we would not be the institution we are today. And I can't tell you that the access that people have would be available. That's the reality, because of the difference between what we're paid and what, again, if you assume the payment is at the Medicare and Medicaid level. But that's not just true for us, that's true for every hospital in America, or virtually every hospital in America. It's certainly true for the places like us, UCLA, USC, Stanford, where the gap is larger proportionally in our places because of what we do clinically. The capacity to do what is done in a place like Cedars-Sinai or Stanford or UCLA, the capacity to do that takes a certain amount of people, equipment, and space that doesn't exist in smaller places. And we also are the places where the discoveries that I just alluded to is being done. And it's also the place where training tomorrow's doctors and nurses and pharmacists, imaging technologists, that's where it occurs. By the way, and those people then go and work in the freestanding imaging centers or community hospitals. We don't complain about that. It's our mission. That's why we exist. But it does make us more expensive, and the government only pays a fraction of what that costs. For us, in our case, frankly, we're able to do what we do today thanks to the incredible support we get from the community for our research activities. That's a vital part of our sources of revenue.
Very much for your presentations. You're very clear and very comprehensive, and I'm enjoying it.
Thank you.
This is strictly an anecdotal sample of one. Mm-hmm. I met a person in a pharmacy in the Palisades and said, well, what do you think of the Affordable Care Act? He says, well, I started out about $3,000 a year, and my deductible was about $3,000 or something close to that. The Affordable Care Act came along, and I'm now paying over $10,000, and my deductible has risen to $7,000,
right.
And I'm really suffering.
Right.
And also, I don't know if it has anything to do with it, but there are some things that he didn't need. He's not going to have a baby. He doesn't need that kind of care.
Right.
So I'm just wondering if you have any ideas on what's going on in that regard.
Yes, so as Hank mentioned, I was the chairman of the American Hospital Association at the time the Affordable Care Act was passed. And I will tell you, personally, I am in favor of the country figuring out the answer to how to get people covered in a way that people can afford. And that was the interest of the American Hospital Association at the time. The Affordable Care Act, like any major piece of legislation like that, whether it was Medicare and Medicaid in 1965 or name your big piece of legislation, it's impossible, literally impossible to get it exactly right the first time. And if you remember, the Affordable Care Act only passed with Democratic votes, not one single Republican vote. By definition, there's going to be a significant fight afterwards, both about revisiting that question, but also about how to change it. So, and I'll be the first to say, having been up close and personal with it, and those of us who worked on it, everyone acknowledges it. It's not perfect, but it was the best one could do to get through, to get something passed politically, to move the ball forward. The answer to your question, at the heart of your question, is a matter of kind of philosophy about health insurance. And that is, it's kind of the question of, to what degree are we our brother's keeper, to use that phrase? To what degree, from a societal standpoint, should the costs of disease or medical treatment, in one way, shape, or form, be shared more uniformly among all of us? Or to what degree should the cost of that essentially be tailored to the individual? The Affordable Care Act was definitely an effort to move the needle much closer to the former, trying to, because it established a defined, a set of benefits and mechanisms like that. Those are the challenge when you move, as you move off of that, the question then becomes, well, where do you draw the new line, right? What things are covered and what things aren't? And from the cost standpoint, a lot of it's hard for me to answer the question in specific. I'll just say this. First of all, contrary to common belief, the Affordable Care Act did not create a national health care system or a national health insurance program. It created an experiment, a 50-state experiment, because how it was designed to be implemented was designed state by state. California has chosen a particular path to implement the Affordable Care Act, and there may be ways within the spirit of the Affordable Care Act that could adjust for the kind of concerns that you described. The problem is, or the challenge is, all of it applies to the individual market. Where your friend purchases their insurance through the individual market from what you're describing. And what complicated things this year is, without going into the details, there were a variety of things done through executive action in Washington that destabilized further the insurance market, the individual insurance market. And so the actuaries, who are the brains in the insurance companies, they're in the business of managing risk. And so as a result of the things that put into question things like how many would be covered, who would be covered, invariably people who are charged with deciding how much risk to take, they tend to be on the conservative side. They want to avoid a risk. And so built into the premium structure that your friend is experiencing is an assumption by the health plans that it's going to be more expensive than it has been because of they're not quite sure who's in the pool, right? When it comes to insurance, the larger the pool, the more the cost gets spread out. That's among the reasons why employer-sponsored insurance tends to be cheaper than in the individual market. Employer-sponsored insurance, the employer knows who they're insuring, and they have an experience with that population. In the individual market, there's a very broad array of people in the individual market, some with a lot of illness and some who are very healthy. And the people who did have the most significant impact, so it's on one hand, on the other. On the one hand, the people who had the most significant negative impact were healthy people who were buying insurance programs with narrower benefits. The people who did benefit are people who were sick and who otherwise couldn't get insurance before, literally in some cases because the insurance companies wouldn't issue it because they had a pre-existing condition. So that's why this whole question of financing healthcare is full of a bunch of trade-offs. Somehow or other, we have to figure our way through it.
That despite the fact that we pay more, well, significantly more than any other developed country for health care,
Right.
the results we get in terms of life expectancy, mortality during childbirth, etc., are in the lower half of the pack. They're poor to middling. They're at the Romania level.
Right.
How come we get such poor results for paying so much money for it?
Right. It's a great question. So first, the answer lies in the diversity of America, socioeconomically and otherwise. America is a much more, while Europe is experiencing immigration and its populations are becoming more heterogeneous, America is a much more heterogeneous population, number one. Number two, the socioeconomic diversity in America is much broader. And besides the things in our genes that cause disease, what one's lifestyle is, either related to personal choice, but significantly related to your socioeconomic status, is significantly impacted by that. Those other countries that you mentioned, there's some interesting data. If you compare how much the U.S. spends between social support services and medical care, and you compare how much the other developed countries spend, they tend to become equal. The difference is we put all our money in the rescue system. We put our money in the rescue system. We don't put our money in the social support systems on the front end. And again, those reflect the cultural values, by my observation, of the different countries. Last comment I'll say is with regard to things like life expectancy, whenever you read that, look, and in all of these things, including what I'm saying to you, ask the second and third question underneath it. So with regard to life expectancy, if you back out death by violence in the United States, the life expectancy in the United States rises significantly and starts to become not so different than those other countries. So it's complicated, like many things. As the president found out, healthcare is complicated. Yes.
I have a question for you. Oops. Okay.
Yes.
Mike. It's on. Okay. I have an American friend who worked in England for one of the very large pharmaceutical companies.
Right.
And she came back to America for some ailment of her family's.
Right.
When she came back home, she said that the same drug in England was 1/10 the cost
Right.
of that drug from that company
Right.
in the United States, and I was
Right.
wondering why.
Yeah, it's very simple. In other developed countries, the government negotiates with pharmaceutical companies for the price. In the United States, we don't do that. I'm not saying which is right and wrong, but that's a fundamental difference. One other quick thing, back to the other question, why it's more expensive here, also has to do with the administrative complexity in the American healthcare system. We and the health insurance companies have armies of people who basically are managing the flow of claims back and forth. So, and there's no question in my mind, short of single payer, there is a way to take out that cost in the system, which is wasting a lot of money. What it would require is for insurance companies to not try to compete on their administrative processes, and agree to things like a common billing form and other things that just simplify the billing process, because it is a terrible waste of money. Yes, ma'am.
My question is actually to address to what you just said. When I hear nurses getting 100 plus, they deserve every penny of it. But when I hear the insurance CEOs get 32 million bonuses on top of their income, that raises my hair.
Right. Yeah, I don't have a good answer for you other than to say, in America, and it's a capitalist society, and there are markets. I'm not saying the market's right, but all of this is a function of the markets for their positions. I'm not defending it. I'm just saying that's what's happening in the market for the positions. Yes, sir.
Thank you so much for your insightful overview of the American healthcare system, which is amazing. My question is maybe somewhat cynical because the incentives in healthcare are for doing procedures and not for preventing them. How can we shift our culture so that we all buy into we have personal responsibility ourselves for the choices that we make for either early intervention and prevention rather than getting sick and saying, fix me, doctor?
Right. Yeah, no, it's a great question, and one that I personally have been I am personally in CedarsSinai is supportive of, is changing the finances, changing the payment system to do what you just said. And the mechanism, the most straightforward mechanism to do that is something called capitation, where physicians and hospitals are given a fixed amount of money to be able to care for a defined population of patients, and that money is used to try to manage the care of the patient for a year. It's usually these things are done on an annual basis. And actually, in that regard, about 38% of commercial insurance payments in California use that very model. So here in California, we've actually, and Kaiser, for example, Kaiser is that model. That's the payment model that essentially the whole Kaiser organization operates on. And historically, hospitals and doctors have all been paid for what they do. And so the transition to what you're describing is underway. It will continue to take a while. Some employers, for whatever reason, prefer to keep using the PPO system, if you're familiar with that term, which is, the PPO system too is changing, where previously doctors and hospitals were paid for everything they did without a lot of question about can you do it more efficiently or can you do it with higher quality. And so even the PPO system is changing to put physicians and hospitals at risk for providing the care efficiently and meeting certain quality thresholds, which I think is another step in the right direction. It goes back to my point about why doesn't it go to one? I go back to what I said earlier. Americans love choice. And there are many people who are uncomfortable with having their health care financed in a capitated way. And so the market is responding and still giving people choice.
The RAND Corporation did a study of healthcare and found that they found objective standards of care. And compared to those standards of care, they found about 50% of healthcare was unnecessary. Right. And about 50% of the healthcare that was needed was not being delivered. That's a pretty serious mismatch in applying resources. What could we do about that?
Yeah, I think the number's more like 30%, but it doesn't matter whether it's 50% or 30%. It's still a lot. So a couple of things. So with regard to that study, what it is pointing out is the difference between what can be done, what works, and what doesn't work. In that regard, sophisticated organizations like us and others actually have in place, working with our physicians, a variety of mechanisms to help both help on an individual patient basis and then work with our physicians collectively on larger questions. So, for example, in the ambulatory setting, the American Board of Internal Medicine created something called Choosing Wisely. And it basically are what are known guidelines for how to treat certain admittedly simple conditions in the ambulatory setting. So we have built into our computer system a way that when physicians are seeing their patients, that information is made known to them. They still make their individual their individual professional decision, which personally I think you do want your doctor to make their individual personal decision, but it does have an influence on the decisions doctors make. And so, for example, we basically reduced ineffective or unnecessary care by about $3 million last year using those kind of systems. Everything has a downside. The physician experience with these systems can really be frustrating sometimes, and part of the challenge is to make those things easier to use and less interfering with what the doctor's trying to do, but still get to the same result. The other thing I would say, though, what the RAND study doesn't speak to, and no one is really addressing, is how much needed but unprovided care is going on. And there have been some studies done that suggest an almost equal amount is also occurring. So, there's two sides to it, but there really is. You should know virtually every hospital in America and physicians are working very hard to answer that question. Where the challenge comes in is the most expensive medicine is in the most complex medicine, where the clarity of what the right path to do is not so clear. And so, there's that challenge. The things where it's clear tend to be simpler. Nothing in medicine is simple, but they're simpler. Yes. Here, I'm sorry.
Is this working? Yes. Yes. Hi, I'm a physician, semi-retired. One of the things I want to make 2 points. One real quickly about the cultural aspects of our country in terms of the Affordable Care Act. One of the things that you're not hearing it? Oh, I'm sorry. Thank you. I was going to make a comment, which I'd like to have your response to. About the Affordable Care Act and spreading risk around. We have many friends who have younger adult children, and I hear it all the time. Well, we're not sick, so we don't want to pay for the insurance. Of course, one automobile accident, and then they're in the emergency room on the public tab is what it amounts to. And we actually have seen that in effect as well. I think that the government has done a very poor job of educating the public. You're not hearing me? I'm making a comment about the cultural aspects. Well, the question is this being addressed? Okay, I can't finish my question if I don't give you background. The other thing to mention is the dispersion of large hospital systems. The Wall Street Journal had a very good article about how to get care out of the centers and closer to homes. Do you mind commenting on that?
Sure. So, yeah, with regard to the last point you made, so there's no question that part of the effort to make healthcare more affordable is taking advantage of moving things out of the hospital that used to take place in the hospital, and to shorten the amount of time people spend in the hospital, both for cost and quality. Hospitals are great places when you're really sick, but you also want to leave as soon as you can. And so there are a variety of things that we and other organizations are doing to create those kind of places where people can get care in a less expensive setting. We've developed a number of ambulatory surgery centers, the urgent care centers I was mentioning earlier, and things of that nature. So all of that is part of the transition of moving things out. But that's only going to be as doable as the developments in medicine and technology allow that to be done. Just like, as I mentioned, when minimally invasive surgery came along, it revolutionized the length of time people spend in hospitals. Imagine how much more we'd be spending today if you still stayed a week in the hospital to have your gallbladder removed. Right? Whatever it costs today, it would be a heck of a lot more expensive in the future. And the one of my frustrations, if I could express it, is oftentimes in the lay press, Wall Street Journal, New York Times, whatever, I have to say I think there's a total misunderstanding of what the motivations and interests of hospitals in America are. There's an assumption that somehow people are doing everything they can to keep every patient in the hospital as often as they can and as long as they can. The truth is, back to the question about international comparisons, if you look at how often people are admitted to hospitals in the United States compared to other developed countries, and if you look at how long they stay when they are admitted, America's at the top of the list. So the use of hospital services and the length of stay is better than those other countries. It gets expensive for the reasons we talked about. Shorter. Sorry if I misspoke. Shorter. So anyhow, from our standpoint, more to come. As much as we can do, we'd love to do.
Contrary to what you just talked about, it's just personal experience in our family that people are being sent home too fast. And before they can be really taken care of at home, when they're still in too much pain, and they're pushed out of the hospital, and also with births, that they're sent home, and there needs to be, how is that being addressed? I don't, besides the money, saying you're saving money by getting them out of the hospital faster, but some of those, but what is the cost in terms of people going home too fast?
Right. So those kind of things are measured on a regular basis, and there's data that the state collects in terms of issues that could be associated with that. And there's a dialogue that takes place around whether that's occurring. So there's a regulatory oversight mechanism with whatever its limits are that tries to track that. I don't disagree with you that there are times when that occurs. And the challenge is, anytime you put any new system in, there's going to be a learning curve until you work your way through it. And unfortunately, I think it does happen where the scenario you describe occurs. All I can tell you is that the people who are providing the care are very concerned about their reputation, including the kind of feedback you describe, and are highly motivated to make sure they change things when and to try to recover around the specifics and in the immediate moment, but also take a look at their systems to see whether they can be changed. Yes, Herb.
Thank you, Tom. I appreciate your very insightful talk, and as a physician on the staff of Cedars for many years, I've watched you lead Cedars from a community hospital to a major international center.
Thank you.
My question is about Alzheimer's disease, which, if not now, by 2025, will be the major medical problem in the country today.
Right.
And I have heard say that the patients alone, they take a lot of money and they return nothing to the community. I've heard say that the system can be broken by Alzheimer patients. What are you prepared to do about that, and how's that going to play out?
So you're absolutely right about the tsunami of Alzheimer's, that's probably going to be one of, if not the biggest consequences of the aging of America, proportionally, as America lives longer and the diseases of aging, starting with Alzheimer's, become more prevalent. For us as an institution, what we're doing is adapting our ability to care for those patients when they're in the hospital. And in the ambulatory setting, at least for the physicians who are part of our medical network, arming them with whatever is available from both from a treatment standpoint to slow things down to the extent there are proven methodologies for that. But also, we're currently looking at the question of support groups and what we can do as an institution to offer support groups for family members of Alzheimer's patients as much as the patients themselves, which is, I think, an important part of it. From a societal standpoint, I think, first of all, I do not think policy decisions will not be made that will significantly compromise the care available to Alzheimer's patients. On the other hand, but it could play out. It could play out in the way certain things related to Alzheimer's patients are paid for. So, for example, there's a discussion going on now, maybe going on about Alzheimer's, but whether the very, very high cost things, because Alzheimer's affects people under 65 as well, whether or not the things like that are extremely high cost should somehow be broken out and financed in its own way to avoid problems like what you're describing. But it's going to be a huge challenge. I don't have an easy answer for it, and everyone's going to be scrambling.
I have a two-part question.
Yes.
Both relating to financing of medical care. The first question is, are you familiar with, or does it even exist, economic research or forecasting as to a single payer system for the entire country, assuming current premiums that are being paid in the private market, employers, and by taxation, to provide treatment at the level that is currently being experienced.
Right.
So, and frequently referred to as Medicare for all.
Mm-hmm.
The second and related question deals with, to what extent has the switchover from nonprofit to profit-making affected the healthcare insurance industry, and to what extent is that costing us all much more than it should?
Yes, so with regard to both questions, there's been research done on the question, on both questions, and I would say the results of those have been, there have been competing answers. So there have been studies done that indicate that that the conversion from not-for-profit to for-profit insurance costs more money. Everyone acknowledges, on the one hand, there is the cost of returning value to shareholders, right, which is by definition part of for-profit. Those on the other side would argue that the for-profit motive causes the insurance company to be more efficient and more effective at doing the work they do. I'm not here to pass judgment on either one, but to answer your question, there are studies and they come down on both sides of it. With regard to single payer and the cost, there are studies that have been done to project things at a national level. To be honest with you, I don't recall the numbers standing here today. What I would share with you is when that question has been asked here in California, taking all of those numbers and putting them together, at a minimum, the additional cost necessary would be something like $200 billion, and the highest number is around $400 billion. And so, and frankly, as Vermont and Colorado have tried to do the same thing, they ran into a similar problem, that when you make an effort to try to combine things like that and come up with a way to finance it, it ends up being more expensive. The other part of that is the unknown. Let's assume you can take all that money and redistribute it somehow. The other question is how does that redistribution affect the delivery system, and what the delivery system is after that. How many physicians participate, how many hospitals can remain viable, things of that nature. So it's a huge question. At a minimum, is one that no one should rush into. And I don't think it necessarily, and my own feeling is there are other solutions short of that I think can be effective in solving the problem if we have the political will to do it. But just like it took the kind of political will it took to to establish the Affordable Care Act was a huge undertaking. The political will to do that may even be more difficult, because in the end, as one of my mentors advised me many years ago, to get something done, and when it comes to health policy, there are a lot of choices. It has to be economically feasible, has to be socially acceptable enough to be politically viable. And solving for those three things is not easy. It's a third rail for politicians. Again, not a defense or anything. For people in political office, it's a third rail.
I'm curious. I have seen that we can use technology to do diagnosing between the physician and the home, a patient at home.
Right.
I haven't seen very much about how we're advancing on that capability, but it would seem that if we all have computers, then the ability to interface with at least a secondary, a nurse,
Right.
there are some telephone lines for nursing. What's being done in that area to improve the cost and the availability and access to primary exams that would maybe be preventive?
Right.
Or at least initial?
Right.
Thank you.
So, virtual technologies of all type, whether over a computer or over your phone or whatever the case may be, there's an enormous amount of work going on, and it's being adopted in healthcare organizations around the country. So, it's already adopted and is being adopted by more. So, in terms of video visits, for example, we're on the verge of launching a video visit capability in our primary care network, as one example. Many dermatologists are making use of that, either in a private office or otherwise, for, again, what I'll call primary level dermatology kind of work. So and I can tell you this, there are people in Silicon Valley and otherwise around the country, and there's an enormous amount of venture capital funding and private equity funding, venture capital mostly, going into funding the companies that are trying to overcome the technological barriers to make that as easy as possible. So it's absolutely one of the, I made reference to it in my comments, didn't get into a lot of detail, but it's absolutely one of the significant growth areas going forward, is to basically advance exactly along the lines you're describing. There's someone over here. Oh, I'm sorry.
Yeah, hi. I am a Kaiser physician, or I have been a Kaiser. Have been a Kaiser physician, and am currently a subscriber, a satisfied subscriber. And
sure.
I worked at Sunset, which is a tertiary care hospital. Is it working better now? Now?
Yeah.
Okay. And I would like to know, as you mentioned before, Kaiser has a setup where it has an insurance company and a medical staff and a hospital network. And they have the ability to negotiate with one another on an annual basis, depending upon what their perceived income is going to be and their expected expenses.
Right.
From my point of view, it works very nicely. To my knowledge, it has not been considered as a model seriously on a national level.
Right.
Although Kaiser is all over the country. What would your objections to the Kaiser system be, other than the fact that some people may not have the last word in their choice of physician all of the time?
Right. So you're right about Kaiser, and Kaiser has significant pluses to it, and also significant advantages compared to their other commercial insurance company competition. Some of those are on the public policy side. I won't go into that, but Kaiser, first of all, Kaiser came, as you know, Kaiser came into existence first as a way to finance health care for employees of Kaiser Steel back in World War II. And since then has grown essentially organically. And so Kaiser, as a health plan, has grown its physician organization and its hospitals, and located both of those to essentially meet their goals of growing the subscriber base for Kaiser. Compare that with the rest of the way the American healthcare system has grown up over the years as largely individual private practice physicians operating in either one-person offices or groups of 10 or 15. Of course, that's all changed now. But and then hospitals that have their history, like Cedars-Sinai, goes back to the turn of the 20th century. Most of the rest of the hospitals in the country grew up, out of their Catholic or whatever not-for-profit organization and community sponsored them. And so they're a set of competing, what we have today on the non-Kaiser side are competing insurance companies, Blue Shield, Blue Cross, Aetna, Cigna, on down the line, and competing doctors and hospital systems. For me personally, I think in order for America to ultimately get what it wants, I think we do need to see the development of systems like Kaiser. And I don't mean the Kaiser model exactly, but one in which there is a unified health plan, way to finance healthcare, and a way to deliver it over a defined population. In order for that to occur, there has to be significant legal and regulatory change. So, and unfortunately, undeservedly, I believe, the whole issue about consolidation in healthcare has developed a bad name, because, like in everything, there are some outliers. There are some bad players who abuse the benefit and don't carry out the benefits of consolidation and abuse the things that consolidation can let anyone to do. But I fear that from a policy standpoint, we're avoiding facilitating further development like that because of the concerns. But in terms of if you want to take out, so on the administrative side, for example, the administrative costs of the Kaiser health system are a fraction of what they are in the non-Kaiser commercial insurance company. They have one way. I mean, first of all, they just pay their provider. They just pay them. There's an accounting, don't get me wrong, but there's nowhere near the complexity of the billing that has to take place. And as a health plan, they do everything within the plan. That's not entirely true, but most of it is. Whereas at Cedars-Sinai, we probably have 70 different contracts with insurance companies. And we have the administrative infrastructure it takes to bill and collect for all of that. That adds cost, and it's not cost related to caring for people. With all of these things, last comment, with all of the things we're talking about, it's very easy to see where you want to be or where you ought to be. It's figuring out politically and practically how to manage the transition from where you are to there. That's really where the heavy lifting is, and it's very hard. And that's why change is hard.
On top of your head, you may know the answer. How much do the illegals cost your hospital?
Yeah, the short answer is not very much. I mean, even in cities that are closer to the border, like San Diego, it's a fraction. It's a tiny fraction of the cost of care in America. It really is. It's a tiny fraction. They don't get to care. They don't get care often, frankly. They do get it in an expensive setting, because when they do get it, they tend to get it in an emergency department. But it's not a big part of it doesn't translate into the cost of commercial insurance, for example, to a significant degree.
We got somebody.
It seems as Medicare holds down its costs at more what it's willing to pay, that the insurance costs in the private sector are going to rise higher and higher.
Right.
And eventually, that was going to lead to political pressure, which will further squeeze out the private sector, which you described as only being 30%. Is that the way you see things going?
Yeah, I think there's no evidence that the government is interested in paying more relative to the cost than they are today. And if anything, there's This is not a political statement, it's a practical reality of the federal budget. Given the Tax Reform Act that took place and the reduction in taxes in America, when at some point, the question about do deficits matter is going to surface again. And when they do that, Medicare is going to be high on the list of figuring out how to pay less, not more, because it is a big part of the budget. I mean, let's be clear. Medicare and Social Security are big parts of the budget. You know, defense is the biggest, and then followed by Medicare and Social Security. So it's inevitable that in that process, the pressures on the government side to pay less will be greater. Private insurance will get more expensive, and there will be change. But between now and then, what I worry about is between now and then, in an effort to keep commercial insurance viable, I do have serious concerns about how that plays out in commercial insurance coverage, and what insurance, what hospitals are in networks, what doctors are in networks, and a whole variety of things that may be well intended, but short-sighted from a community standpoint. Because it's, again, it's the way the free market works, and you all know free markets produce good outcomes, and they produce unintended outcomes. So that's going to be a challenge. Right, as do all markets. Right. Thank you very much. Thank you.